Okay. Okay. Hello everyone. Good evening. Now AV is fine? Yes? I hope it is fine. हाँ अब आ गया है ऑडियो. Good evening. Yes, now I think it is audible. Is it audible for everyone? Yes? Can we start? Very good. Okay, so welcome everyone, and all of you know that forms are out, and obviously it is a trigger factor, right? For many, it will be a good thing. For many, it will actually trigger out anxiety. So first of all, how are all of you feeling? कैसा लग रहा है अभी? Relaxed, tensed, whatever you are. Fine, let us. Whatever you are feeling, beta, everything will be sorted. Okay? Everything will be sorted, whether the exam is on the due date or it is, whatever happens to it. You have to keep on studying. If you do not study and you are into an anxious state, so for that I have one very personal story. Fine. So there was one book release of my friend, and I was to speak something over there, and I prepared what I will say about my friend. It was long back, and what I will say about the book, and I prepared well. Fine. But 20 days I made the speech, I rehearsed, but when that day came and I had to speak, I don't know what happened. Suddenly jitters, suddenly anxious, suddenly, I was like, okay, now I have to speak. And I was a good speaker, I was prepared, but just because I got a little bit of anxiety at that point, obviously for the first few seconds I fumbled. That was long back. But for all of us, always I remember this thing. We have been preparing for the exam from 1 year, since 6 months or 4 months or 8 months. And when the exam is near, if we get anxious, what will happen? What will happen, beta? So beta, if you are excited, fine, good. If you are anxious, then control it. Try and control it and start studying. That is the only thing. Once there was an interview, and an IAS officer was asked, okay, you have to do something. How do you get motivated? And he said, I don't get your question, sir. I don't get it. What are you asking me? The examiner said, okay, you have to do a work. What will be your motivation? And he said, if that thing has to be done, it has to be done. There is no motivation or anxiety or depression or anything. So if you have to give the exam, get a seat. You have to study. There is nothing, there should not be any role play of any form, anything, which will disturb your study. Fine. So, हाँ Dr. Dipesh, okay, propranolol, nahi. I believe कि भाई, okay, fine, we can, handle everything if we think right. Fine. So think right, everyone. Everything is going to be sorted for each one of you. Because, guess what? But yes, we are making our lives. We are working hard. But, somebody over, in the skies has written our destiny. And that person or him, they have written it nicely. They have written it a beautifully story for all of us. Fine. So what is the rule for my class? What will you say? I can't do it. I might do it. I will do it. I can and I will do it. Fine beta, jaldi se bolo, speak and then let us start. Very good. So whenever you are anxious, just remind yourself of me. If you're anxious, you're spoiling your paper. Fine? Okay ji. Chalo, next beta, yesterday we did COPD, asthma. Now, what is the most common cause of emphysema? What is the most common etiology of emphysema? It is smoking. Fine, very important question. So, long back there was one question. What treatment protocol has the maximum effect on treatment of emphysema? So, that is cessation of smoking. Yes, I can do it. That is cessation of smoking, right? Important. Thoda sa, we have to apply our brain. Emphysema is because of smoking, right? So if we cessate smoking, then the treatment is successful. And of course, if they ask you what is the treatment protocol, you already know we have to give oxygen, right? It is irreversible. We have to give oxygen. So that is the treatment. Okay. Next beta, not a very probable question, but these all options can be in the questions. A person has so and so history and he has, the definition of chronic bronchitis, which I told you to learn yesterday. What will be the complication in this, right? So bronchitis, mostly polycythemia occurs, and emphysema, mostly pneumothorax can occur. Okay, so 2 additional points. Now, coming to bronchiectasis, very recent examination question. And it is very easy. It is not at all difficult. It is very easy. Bronchiectasis, is it reversible, irreversible? Irreversible, because reversible is only asthma. Dilation. It is irreversible dilation of the bronchi and the bronchioles. Then what is the most common site? Lower left lobe. So LLL. Fine. Most common cause cystic fibrosis. But here in cystic fibrosis, which is occurring in children, it is in the upper lobe and bilateral. Fine. So if they ask you what is the most common site, it is the lower left lobe if it is occurring in the adults. If it is occurring because of cystic fibrosis, upper lobe is affected. Right? What will be, see beta, the question is this, irreversible. Then how the question is framed. It will be a long question. Right? The mucus production is there. So purulent cough. Then when you change the direction of sleeping, when you get up, when you sleep, when you do sideways, the mucus production is altered. This is a very recent question from a very recent exam. And we can also get this thing. Now, these two, they indicate, of course, the bronchiectasis. So it is actually, position dependent. Fine. In this, clubbing occurs. So clubbing I will be doing again. Fine. Next, what are the 2 syndromes associated with bronchiectasis? Young syndrome. In Young syndrome, it is bronchiectasis, rhinosinusitis and decreased fertility. Right? And Cartagena, which we will be doing. Fine. Next, X-ray. In the X-ray, you are going to just repeat with me. Tram tract. Okay, Dr. Ayush, the complications. See, but it's not a complication. Just, you will be given an outline of chronic bronchitis. You will know it is a chronic bronchitis patient. And then they will ask, okay, what will you see in this patient? Fine. So, in that patient, options can be polycythemia, pneumothorax, and many more. Right? So, you will mark polycythemia if it is chronic bronchitis and pneumothorax In emphysema, because in emphysema blebs formation is there. In emphysema alveoli, they are losing their structure, and you know what is happening, they are becoming one big ball, right? Instead of small alveoli, they are losing their architecture. Fine. So because of that, the pneumothorax can occur. Fine. Next, tram tract. I'll just show you the x-rays. And signet rings in the CT. Just remember these two words, beta. Tram tract appearance. Tram tract matlab train tract, right? Signet rings, which I'll show you, and finger in gloves. If these three things are there in the x-rays or in the CT, then there can be only two diseases the person is talking about. One is bronchiectasis, the other is most common cause of it, cystic fibrosis. Fine. What is the treatment? I told you postural drainage, because depending upon various positions, the drainage is more or less. Right? You might give antibiotics, bronchodilators, ye kuch nahi hai. But there is one more question. It is not a pre-malignant condition. So which of the following is true about bronchiectasis? It is reversible, irreversible. Which is the most common site? Remember cystic fibrosis and remember the Carter-Jenner syndrome. Fine. Tram tract appearance, signet ring and finger in glove. With this, we will come to cystic fibrosis. Right? Clubbing भी बहुत important है, which I will be doing at the end. But for now, just remember clubbing is seen in bronchiectasis, and therefore it is also seen in cystic fibrosis. Because bronchiectasis and Dr. Ayush both hai. But the question cor pulmonale bhi to I have written beta. Cor pulmonale also is the thing. But the question was on polycythemia. Polycythemia cannot be a complication. है ना? Polycythemia is something that you find and it might lead to complications. Fine. So I have written cor pulmonale also. Just give me 1 second. I'll just show. Yes. See, polycythemia and cor pulmonale. Just imagine, beta, cor pulmonale is a complication. Polycythemia is a finding which might complicate, right? But the question was this in a recent exam, so I highlighted it. Dr. Dipesh, polycythemia bhi hota hai, but it was a new question, right? Cor pulmonale, of course, is more common in bronchitis. Done, everyone? Okay. Next, everyone, cystic fibrosis. Okay. Now, cystic fibrosis, one fact that we learnt, both of them will be having clubbing of fingers. Cystic fibrosis is autosomal recessive. It is due to CFTR gene mutation on chromosome number 7. And the most common mutation or deletion is deletion of phenylalanine at the 508 position. Right? It is written like this, where the triangle signifies deletion. F is phenylalanine. Right? Clinical features, please remember, overall, please remember what will happen in this. It will be, the child will be having very thick secretions. Because of those thick secretions, there will be a lot of pneumonia cases, right? Lung infections. So, what is the most common infection in cystic fibrosis? Pseudomonas. Fine, pseudomonas, very important question. If they give you overall pseudomonas, adults, pseudomonas, specifically children, then you can mark staff. Fine. Next, in this, just remember the ultimate treatment is lung transplant. Fine. In the GIT, you see meconium, ileum, fecal impaction. Infertility is there. Because there is a lot of chloride loss in the secretions, any secretion, okay, that is why hypochloremia occurs, hypokalemia, hyponatremia. Steatoria is what? Fat loss in the fecal matter, right? So fat soluble vitamins they are also lost. This particular child will have edema because of hyperproteinemia. It is known as salt baby syndrome. Salt baby syndrome because there is chloride loss in the sweat, and this has become a method for neonatal screening, right? So as soon as cystic fibrosis comes, you must know thick secretion, lung infection, GIT also involved, even the reproductive system is involved, and chloride is present in the various secretions of body, right? And chest x-ray, finger in glove sign, I'll just show you. And mucus plug. Why mucus? Because it is very thick. Very, very thick mucus is there. Fine? Okay. Now, see beta, tram line sign, it is seen in bronchiectasis, and if cystic fibrosis is associated with bronchiectasis. So tram line means the railway track lines, right? Next, these are, I don't think so we will be getting CT, but this particular diagram is very easy. So signet ring, as soon as this comes, the question is about bronchiectasis or cystic fibrosis. See this beta. See this image, very beautiful image. These are your fingers in glove, right? Fingers in glove, right? And similar thing you are seeing on this side, where parallel mucus plugs are there, right? So this is finger in glove appearance. So I hope now you'll never make a mistake if these three things come. Tram tract, finger in glove, right? Bronchiectasis, both cause clubbing. Fine. Now again, a very recent exam question, that is ARDS. ARDS, acute respiratory distress syndrome. Why many questions are coming from this? Because this particular topic is associated with COVID, right? So three causes for this sepsis. First is sepsis, gastric aspirations, head injury. Fine. The names are also very important, beta. They can ask you the names also. So high altitude pulmonary edema, acute lung injury, DAD, diffuse alveolar damage. And you know what? This is a very characteristic feature. So this was once a question of ARDS. Stiff lungs, beta. Right? The lungs now cannot stretch. Okay? And fifth one is very important, non-cardiogenic pulmonary edema. Now here only just learn one line. There are two types of pulmonary edemas. One is cardiogenic, other is non-cardiogenic. Cardiogenic, you all know, something is related to the heart. Non-cardiogenic pulmonary edema is ARDS. Very important question, bete. ARDS is very important. Okay? Next, just remember here, the PCWP pressure is less than 18 mmHg. That is the hallmark of non-cardiogenic pulmonary edema. So either this question can come कि ARDS क्या है, what it is, or it can come what is non-cardiogenic pulmonary edema. This is related pathology. Now what happens in ARDS? There occurs some injury to the lung because of which protein-rich fluid comes out and it is deposited in the interstitium. Right? This is also very important question. Which failure is it? Respiratory failure type 1. Right? This is a surgery question. Which catheter is used to measure PCWP? That is pulmonary capillary wedge pressure, Swan-Ganz catheter. right? Most common cause is sepsis, COVID, viral, any sepsis, bacterial, fine. But in COVID also this was a major problem, right? Direct lung injury, pneumonia. Indirect lung injury is sepsis, most common cause, right? How will the patient present? Sudden onset dyspnea. Suddenly, he was ill, but then sudden onset dyspnea and cyanosis occur. Very recently, Berlin criteria has been asked. So, Berlin criteria is nothing but ARDS. Repeat karo and learn karo. Okay, Dr. Anusha, I will show at the end. Tram track image. देखो simple है जैसे imagine there are 3 railway tracks which are running parallel to each other. Imagine karo. Imagine every one of us know what is a railway track. So imagine you are outside and there is a big railway field where there are 3 railway tracks and they are parallel running to to each other. That is the tram track appearance, right? Okay, now Berlin criteria, important question. What is the criteria used for ARDS? Berlin criteria. What is it? ARDS, acute onset, sudden onset within 7 days of a sepsis, fine. Decreased PaO2 by FiO2, reduced. D say diffuse bilateral opacities on the chest x-ray, and this is known as whiteout. And S, Swan-Ganz catheter. I told you Swan-Ganz is used for PCWP and that will indicate less than 18. That is non-cardiogenic, right? So all questions of ARDS are sorted if you know ARDS. These are the probable question, beta. Berlin criteria. Which of the following is true for ARDS? And type 1 respiratory failure, so it has come many times. Okay, next. The PaO2 by FiO2, if it is around 300 or a little more, then it is mild ARDS and we call it ALI, acute lung injury. So for acute lung injury, the level of this particular ratio has to be less than equal to 300. For ARDS to occur, it has to be less than equal to 200. So these are the 2 questions which have come. At what value of PaO2, FiO2 will I say the person has ARDS? Fine. Okay. The treatment, you will give the antibiotics, you will use CPAP and steroids, not much important. But Berlin criteria, the PaO2 by FiO2, very, very, very important. Okay, so Berlin criteria again, let us revise. ARDS, acute onset, reduced PaO2, diffuse bilateral opacities, and S से Swan-Ganz याद रखो, yeah, it is a non-cardiogenic pulmonary edema. Very important points, and especially this chart. Fine, just remember 300 है ALI है, 200 है, then ARDS starts, and less than 100 तो severe होता है. इस पे there has been no question कि why it is severe, on what value it is severe. Fine. So ARDS done. Okay. Now, clear beta? Any doubt till now? If you have not understood anything, learned anything, please. No, अच्छा जल्दी से बताओ अब मुझे. Bronchiectasis, what is the most common site? Quickly tell me. Bronchiectasis, most common site. Yes, beta. Yes, LLL. Right? So remember it like this. If I give salbutamol, okay, bronchiectasis, COPD, asthma, they are the diseases, for which I will be using salbutamol. If I give salbutamol, which of these 3 will show the reversal? Now I will tell you what is reversal. Okay, but tell me out of these 3 which will show reversal, and will there be any reversal in bronchiectasis? Very good. Yes, everyone. Okay, so time for a little PJ. So there was one teacher, right, and a student. So the teacher asked, okay, please tell, okay, what is the difference between thought and illusion, thinking and illusion? So a student said, we are studying, that is what you are thinking, but it is your illusion. I hope that is not happening here, right? You all are understanding everything. Very good. Bronchiectasis, no reversal. Good. Chalo, next beta. Very important. Obstructive, restrictive. Obstructive disease kya hai? When there has been any obstruction in the airway. Right? Right? So obstruction in the airway, that is when, what happens? FEV1. FEV1. What is FEV1? It is when you are expiring, right? Anyone is expiring. How much is the flow or expiration at first second? FEV1. Dr. Ayush, whatever sir has told you in the pharmac, please mark that according to the medicine. Also, it is either epitropium, tiotropium, right? Basically, the category of drug is important. Fine. Okay. Next, beta. FEV1. Now, beta, what is FEV1? The cycle consists of inspiration, expiration. When a person is expiring, then for the first second, what is the value? Right? That is timed values. Right? In obstructive, please learn this fact. In obstructive, there is obstruction in expiration. The expiration is a problem. Fine. So in these people, FEV1 is highly reduced. Fine. And it is less than 80% predicted value. Restrictive का क्या मतलब है? Obstructive मतलब some obstruction, asthma, COPD, bronchiectasis. Restrictive means the channels are perfect. Some problem is there with the lung. The lung doesn't want to work now. When will it happen? Fibrosis. Or when there is some chest problem, kyphoscoliosis, right? Or when there is Guillain-Barré syndrome, or there is some polio, right? Wherein lung is absolutely okay, but outside chest is a problem. Scoliosis, kyphoscoliosis. Fine. In many muscle paralysis, if the muscles are paralyzed of the chest, then the restriction occurs on the lung, and muscles are okay, but now the lung has a problem. The lung has become sad. That is fibrosis. So there are two types of restrictive diseases: intrinsic, extrinsic. Intrinsic means lung is sad. Extrinsic means lung was happy, but the people around the lung, the chest wall, is having a problem. Fine. Okay. So first let us do obstructive. In obstructive, we all know the FEV1, the expiratory rate at the first second will reduce because we are having an obstruction. In restrictive, it is either decreased or normal. FVC, the forced vital capacity is decreased in both or normal in obstructive but highly decreased in restrictive. So if you know these two things, the hallmark question becomes very easy. What is the hallmark of obstructive? You have to learn FEV1 forced expiratory volume 1, right? Next, at the first second. See, when we are doing spirometry, we measure this especially so that we can know obstructive restrictive diseases. Fine. So FEV1 by FVC is less than 0.7 in obstructive and more than 0.7 in restrictive. Right. TLC. Now this point you don't have to ratify, just remember one thing. What was residual volume? क्या था residual volume? Normal respiration पे या forced respiration पे, expiration पे? Please tell me. I told you to learn all of this. What was residual volume? Yes, beta, quickly I should get the answers. Yes, beta. जल्दी जल्दी बताओ. Right, beta. So now there is a person. Okay, see, this is a person who cannot expire, right? Who's having problem in expiration. Obstruction is there, right? And that is why, you know, his the forced expiratory volume at first second is reducing. Fine. आप FEV1 ही याद रखो. Why? Because in exam FEV1 will come. Okay. Now, because he cannot do expiration, the residual volume is going to increase. In emphysema, you know, blebs are there. What are those blebs? They trap the air. That is why the dead space was increasing, right? In emphysema, in various other diseases. So, residual volume increases in obstructive. If residual increases, then everything which involves the residual volume will increase. Fine. So, TLC increases, may be normal. And here in restrictive, TLC decreases. Fine. Whenever we are talking about a restrictive disease, think about intrinsic. Until and unless they specify extrinsic. So if I tell you what happens to residual volume in the intrinsic, then remember it decreases. You do not have to answer according to the Guillain-Barré syndrome, kyphoscoliosis or any other disease. You have to answer according to fibrosis. Fine. Whenever the examiner is making a question, he will always keep in mind fibrosis. Fine. So it decreases. RV by TLC ratio increases in obstructive, whereas in intrinsic it is normal, in extrinsic it decreases. Diffusion lung capacity, which we have done yesterday, normal in asthma, in chronic bronchitis, except just give me. Is there any problem in the lecture, beta? Is it having any lagging? Yes, beta? Okay. So now DLCO is normal in the obstructive except the poor emphysema. It decreases. Whereas in the intrinsic fibrosis ho gaya hai, there also the diffusion will decrease. Now please remember, if you ever forget it, कि भाई where diffusion, just remember beta, emphysema में the surface area is being affected, and in fibrosis the thickness, you know, fibrosis मतलब thick membrane. Now through this thick membrane, the diffusion cannot happen. So both fibrosis and emphysema, DLCO decreases. Fine everyone. So intrinsic, extrinsic, always answer restrictive thinking in mind about the fibrosis. Right? Hallmark question, very important. Residual volume, very important. FEV1, very important. Right? In this, we are just telling the patient to forcefully expire. And that forcefully expiring, at the first second we measure. Okay. Next. Respiratory failure. Done everyone? So what are the hallmarks? How can we differentiate between obstructive and restrictive? They are the various flow rates. What happens to FEV1? What happens to FEV1 FVC ratio? Very important. Correct, bete? Okay. Next important is respiratory failure. Respiratory failure. Very important question. In a single paper, there were 2 questions, which were from the respiratory failure. So type 1 respiratory failure, type 2 respiratory failure. In type 1, just remember, PO2 to decrease hoga. That is a respiratory failure. PO2 will decrease in both. But how is type 2 different? Their PaCO2 increases. Fine. Whereas in type 1, PaCO2 is normal. And what happens? Just remember, P alveolar O2 minus P arterial O2 increases in type 1. Whereas in type 2, it remains normal. This can be a newer question. Till now, the question has come on examples and it has come on the CO2 factor. Right? But this, I am thinking it might be a newer question this time. Fine. Just remember the examples, especially ARDS, emphysema, asthma we discussed yesterday. The first 2 stages are type 1. The last 2 stages are type 2. Severe wala is type 2. So asthma, just answer according to what they have asked. Mild or severe or whatever. Fine. Okay. Chronic bronchitis. Please remember, chronic bronchitis is a very most common cause of this kind of respiratory failure. Fine. Then OSA. And wherever bronchitis is there, we give a low flow oxygen so that CO2 narcosis, CO2 toxicity does not occur. Fine. So this question has also come. Okay, in type 2 respiratory failure, will you use a high flow oxygen, low flow? So just remember, type 2 bronchitis, low flow. Simple. Dr. Muskan, I will explain you the whole algorithm at the end of the class because then it involves a lot of things. Okay? So I will handle your doubts at the end of the class. Fine? Okay. So type 3. Type 3 is perioperative. This has also come. Perioperative, during operation, GA was given, suddenly collapse. And sudden collapse, what happens? Lung atelectasis occurs. Fine. So type 3 perioperative. Type 4 is shock, any kind of shock. Right? Any kind of shock, especially hypovolumic shock. And this leads to hypoperfusion of the respiratory muscles. So beta, quickly let us revise. Type 1, PO2 less, PCO2 normal. Type 2, PO2 is less, PCO2 is high. Type 3, perioperative atelectasis, GA. So, the question will say there was a surgery going on. Suddenly this happened. Type 4 is shock patient. There was a patient of sepsis, septic shock. There was a patient of RTA, road traffic accident, hypovolumic shock. So, this will be the history. Fine? Okay. Done, beta? Done? Next is OSA. Beta, I will take a look at all the doubts in the end, so that we can keep the flow going. And because we have to do a lot, we have to finish the pharmacology also, and we have to finish little bit of micro also. Fine. Then obstructive sleep apnea. How will the question be framed? There is a patient, Ramu. He sleeps in the office while he's in the office. That means daytime sleepiness, somnolence. Then he has irritation and all that will be written, because obviously he's not able to sleep. What happens to this person? There is apnea, breath cessation for at least 10 seconds. Again a question. Fine. And Dr. Asma, which new question from the ARDS? Better, this is present in your notes, but it is just that I wanted to highlight it. So this can come. What is the difference between the alveolar and arterial oxygen? Fine. Okay. It is increased in the type 1, normal in the type 2. Okay. Next, beta. Just remember the apnea. Apnea can be central or it can be obstructive. Central apnea may we see the Cheyne-Stokes breathing, which I will tell you today. What is Cheyne-Stokes? What is Biot's? All of this comes. And here the pre-Bodzinger, which is the pacemaker, is affected. Fine. OSA, I just did type 2 respiratory failure or pulmonary hypertension. Right. What happens? This person is typically obese. Postmenopausal woman, obese, middle age, or there will be some craniofacial obstruction. Right. Some abnormality will be there which is stopping this person from respiration, breathing while he is asleep. Right. What can be that? Transient closure of oropharyngeal airway. So increased daytime sleepiness, decreased libido, snoring, and of course all other problems. So how do you diagnose OSA? Polysomnography. Individual question has come. Okay, what all is there in polysomnography? In the polysomnography, we are using ECG, EEG, EMG, EOG, SpO2, BP, heart rate, airflow evaluation. Everything we are doing. So we are actually assessing a person when that person is sleeping, what all changes occur in the body. Fine. So polysomnography is done for OSA. Many chest specialists, they do all these tests. Fine. So this is a very, very common test now in many of the clinics. You might go to any neurologist or a chest physician, they keep this machine, polysomnography, and they do this test. Fine. Next, treatment. First thing which has an impact, weight reduction. If someone has adenoids, surgery. Fine. If someone has very big adenoids, surgery has to be done. This beta can come. CPAP via nasal mask. We give that while that person is sleeping. If he is not able to reduce that much weight, the CPAP is given. It's a machine and a nasal mask is given so that that person doesn't have apnea. And whatever the problem is, that surgery has to be done. So this you don't have to learn this. Weight reduction important hai, alcohol important hai, daytime sleepiness important hai. Epworth score. And Epworth score has been used for OSA. That is just a single one line question. For us in dental, the scoring I don't think will come. Right. And if it comes, it will just be one question. And sometimes beta, even if you study a lot, you will still not be able to answer a question. Right. In that particular scenario, do not get offended. Do not feel that don't lose your worth. कि भाई I don't know this. No beta, there are going to be questions which you cannot answer. Accept this fact. Even if you have read medicine, even if you have done perio, right, even if you have done PCD, you have done pedo, you will have questions which you cannot answer. Accept them. They are not going to affect whether you get a good rank or not. Fine, because they are same for everybody in India. Okay, maybe only the first ranker can do those. Okay, now question has come on the AHI index. What is this? Apnea hyperapnea index. Fine. Yes, Dr. Aryan, atelectasis तो children में भी होता है. When it happens, when there is no surfactant, we did it, no, hyaline membrane disease. To prevent hyaline membrane disease, we give steroids to the mother. And you know, it is very important, बेटा, हमें कल हमने किया नहीं था lecithin का and sphingomyelin का, what is the ratio, right? All that is very important. So yes, atelectasis can occur. Atelectasis is nothing but lung collapse. Fine, it's a journal term. Okay, AHI, apnea hyperapnea index. Mild, in this mild, 5 to 14 cycles of apnea hyperapnea per day. Moderate, 14 to 29. And severe is more than 30 cycles. Fine. So, beta, please remember AHI index. Please remember polysomnography. Remember which, daytime sleepiness. And this question to be recent question. I'm sure you must have seen it. Breath cessation for it. Yes, 10 seconds. Recent question. You cannot forget it. Fine. So whatever we are doing, it is actually a recent question. Okay. Now, beta, fasten your seat belts because we are going to do TB. Fine, everyone? ARDS, bronchiectasis, individual question, they all can come. Fine? Okay, let us now come to TB. Very important. There is no paper without TB. Either micro, either medicine, either patho, either pharmacology. There has to be either. I think 2-3 questions hamesha always from TB. Always. Fine. Why? Because TB in India is like fire. Fine. It is there. Fine, everyone. Okay. Next. TB. Just remember, beta, TB, primary, secondary TB and congenital TB. Primary TB, beta, it is obviously any TB infection is by droplet infection. Primary TB occurs in those. Please listen very carefully, beta. Each line is a question. Each line is a question. Primary TB occurs in those who have not been previously infected or in children. Fine. It is asymptomatic. Here we see no cavitation and healing might occur with fibrosis or calcification. Fine. In primary TB, we have a Ghon's focus. Less than 1 centimeter. And what is the most common site? It is the lower part of upper lobe. Now you will tell me why upper? Why upper? Or why it is this? Because of the ventilation perfusion ratio. Right? The second area for this can be upper part of lower lobe. Right? So the first one is this. The second one is this. Fine. If they make a focus in the apex, apical region, upper region, right, then it is most probably secondary. Fine. So this particular diagram can come. They can ask you what is the most common site of your the Ghon's focus. Okay. What is Ghon's complex? Ghon's complex is Ghon's focus plus hilar lymphadenopathy. Ranke's complex is when this gets calcified. So calcification of Ghon's plus ipsilateral lymphadenopathy, Ranke's. In the primary, this is a very important repeat question. Very important repeat question. After TB, I will just have a look at the doubts and I will solve them. Delayed hypersensitivity. Repeat question hai beta. Erythema nodosum and flectenular conjunctivitis. You know, they will give you the history of a child and they will give you the photos of erythema nodosum and flectenular conjunctivitis. And you know, you will be asked whether it is primary or what it is. It is delayed hypersensitivity seen in the primary. Cavitation is typically absent. If they write cavitation, then it has to be secondary TB. Right? Cavitation is a feature of secondary, which is the most infective form. This is secondary TB is known as adult TB, reactivation or post-primary TB. Most common site I just made, it is present apically, upper part of upper lobe. Fine everyone? Most common cause is reactivation of primary TB. Then from your oral pathology, you must know what is Pott's disease, TB of spine, lupus vulgaris, TB of skin, Ponson's disease, polyarthritis with miliary TB. What is scrofula? What is scrofula? They also ask what is the most common site for extrapulmonary TB. Then it has to be the lymph nodes. Right? So the scrofula, Ponson's, the lupus vulgaris, Pott's disease, individual question in your oral pathology. Fine? Next, very important recent question beta, direct one-liner, hemoptysis, the hemoptysis, that is blood in the sputum. It is a major feature of TB, right? Primary may not, secondary may it is present. And hemoptysis occurs from which place? 90% from the bronchial artery. 90% from the bronchial artery. Fine? And 10% from the Rasmussen aneurysm. And what is Rasmussen? Which is present at the pulmonary artery level. Right? So bronchial artery, repeat question, learn with me everyone. Bronchial artery is the site for hemoptysis. Most common site, bronchial artery. Hemoptysis is a feature of TB. It is also a feature of bronchogenic carcinomas. Fine. Now, gold standard test. Please remember, you have to do sputum culture. Culture करना पड़ता है, right? It is not just histology. It is not just the ZN staining, but the culture is important. CB NAT is also one of the tests, right? Then this is a repeat question. Contrast in the CT. You see contrast, peripheral rim enhancement in necrosed lymph nodes. Right, this has been a line. What do you see in TB? And I think this question is from the OP, oral pathology book. Okay, what do you see in the CT of TB? That is contrast, peripheral rim enhancement. Peripheral rim enhancement was the question in necrosed lymph nodes. So you have to learn it like that. We will not be getting any CT images, but they might just give you a CT image, write this line, so you should know it is TB. Fine. Backtech is also a test. You must know that backtech किस लिए है? Backtech is also for TB. The Montague's test. Many questions have been asked on this. So please know Montague's test. What happens? We give an intradermal injection of PPD 0.1 ml. And on the flexor surface of arm, and then we wait for around 72 hours, up till 72 hours, and then we see that area. If it is less than 6 mm of induration, then we say it is negative. 6 to 9 is maybe. Sometimes 5 bhi likha hota hai, so don't worry. 5 is also okay. 5 mm, 5 to 9 mm, whatever. Fine. So just remember 5 or 6. 6 to 9 maybe. More than 10 is definitely TB. Fine. Now in this is not a diagnostic test. Why? Because we may get a false negative and a false positive. False negative test can occur in miliary TB. Dr. Shubhangi, कुछ गलत हुआ होगा, ठीक है? Something would have been wrong here. False negative, right? Miliary TB, sarcoidosis, immunodeficiency, and measles. So what you have to remember, miliary TB, sarcoidosis, because sarcoidosis as such is very important. Fine. And of course malnutrition, immunodeficiency. False positive will occur if someone has been given BCG vaccine or has a latent infection. Fine. Okay. Most common, this is from Pharmac beta, most common cause of drug resistant TB is previous treatment of TB. Right? So this is a repeat question. Please keep in mind what is the most common, right? And what is the most common opportunistic infection in HIV? Again, I am repeating TB, TB, TB. If it is less than 200, then what is less than 200? The CD4 count. If it is less than 200, only then we get the pneumocystis jirovecii infection. Otherwise, if they ask you the opportunistic infection TB, India में पूछें TB, world में पूछें TB. Only if they ask you about developed nation, then maybe you can answer jirovecii. Otherwise, it is TB. Most common opportunistic infection in HIV, TB. Right, beta? It is not. If they ask you fungal infection, then you can mark candidiasis. Done? Done, beta? Okay, one more thing about congenital TB which you should know. Okay. Congenital TB, beta, please remember most common site of any TB is lung. But if they ask you primary site, that where will you find, if suppose you find the TB in the liver, then definitely it is congenital. So most common primary site is liver. Right? There are certain criteria, Cantwell revised criteria, which you just go over once, which are there in your notes. As such, no questions are formed here. Fine. So what can be, recent beta, these questions have been coming from the pathology side. So please note, this is not in your notes. And this particular thing, beta, recently पूछा जा रहा है. Okay, so let us add. Rich focus brain. When the focus is formed in the brain, then we call it rich focus of TB. If it is in the blood vessels, we call it Govt. Apical Simon focus. Supraclavicular, the Wolf focus. Infraclavicular, Assman focus. So, rich focus and Assman focus, I have seen they have come in the medical exam very recently. Okay, so it was my duty to add this in your notes. Please add rich focus and Assman focus. You might forget the Simon or Uhl or Govt. You might forget it. Fine. But the rich focus and infraclavicular Assman, don't forget. Recent question hai beta, very recent in the medical exams. Written, everyone? Just take few seconds and please write it. Both are there, Dr. Rajveer Singh, both beta. It is both, but most important is this. Yes, that time in notes we also confirmed from the pathology faculty, and this was what we came to a conclusion. One is more common than two. Fine, so first is what you have to mark, and the second part, the upper part of the lower lobe is the second option. Right? Please make a correction. Okay. Yes, beta, Simon, M. Simon. Apical portion, beta, just if only the apical is involved, we call it Simon. Right? So, rich focus and Assman, beta, these two have come. I have seen the questions. So, even if you forget these, remember rich and Assman. Fine? Okay. Now coming to pharmacology, that is the anti-tubercular drugs. Okay. Anti-TB drugs, beta, always a question. So you cannot mess with it. You should not, miss it. If you have not done anti-TB drugs, please learn it. Okay? So this is my homework to you. If you have not studied, I will be doing. If you have not studied, you have to do it. Because see, beta, in pharmac, there is going to be one question from the diuretics, one question from the diabetic drugs, one question from the various antibiotics which are there. Then one question is going to be from TB. One question is going to be from the blood drugs that we do, the platelet drugs and the other NSAIDs, everything what we do, antiplatelet drugs. So these are the sure short topics from pharmacology. So if you have not done the anti-TB drugs, please do it. Okay? Next, let us quickly revise. Correct. Everyone has written? Okay. Now, anti-TB drugs. Okay, let us quickly revise. Beta, this is one table I want all of you to know. Maximum questions are framed from this. Okay, maximum questions. So if you have not made this chart, please make it once. Yes. Right? So what are the first line drugs? HRZES. Right, you all know the names. So HRZES, they are the first line drugs. Now S now is not considered, right? But still we include this in this table. So first thing is, which of the drugs are cidal? So how to learn? Only static drug is E. Only static drug is E. Ethambutol. Right, you all know the names of the drugs, or should I tell? H is isoniazid, R is rifampicin, Z is pyrazinamide, E is ethambutol, S is streptomycin, which is now not a first line drug. So HRZE are the first line drugs. Right, so only static drug is ethambutol. Fine. Next question which they ask, beta ye baki ka ho gayi? Cidal. Right. Next question which they ask is, which act intracellularly? Intracellularly, which acts? Drug is Z drug. Pyrazinamide. They can twist this question and ask, which drug acts in the acidic medium? So again Z. Which drug acts extracellularly? That is streptomycin. Or they can twist it and say which drug acts on the alkaline medium. Okay, done. Next is hepatotoxic. Hepatotoxic drugs are HRZ and Z, the pyrazinamide, that is the most hepatotoxic. Done. Learned everyone. Pregnancy may what we can give? We can give her. Because obviously a pregnant is always a lady, right? It cannot be a male. So her drugs we can give. HER, they can be given in the pregnancy, but the S drug totally contraindicated. And the Z drug should be avoided. So beta, this particular chart has to be on your tips. Right? Another maybe, if the examiner is in bad mood, then he can give you HRZ, which is used in fast growing, which is used in spurters, which is used in slow growing Mycobacterium tuberculosis infections. Fine. So this is a bad day question, fast growing. So if you have learned this chart, then you go to this fast growing and slow growing spurter thing. Fine. So this chart very, very, very important. S, streptomycin, it doesn't cross the blood-brain barrier. The blood-brain barrier is crossed by HRZ. Next important question is on side effects. It comes, beta, always it comes. Okay, before the side effects, let us first do the mechanism of action. Okay. Mechanism of action, beta. INH is a drug which inhibits mycolic acid synthesis. So see beta, in anti-tubercular drugs, either the question will come from that chart or from the side effects or from mechanism of action. Simple. Okay, only 3 types of questions are there. Maybe regimen is asked, maybe, and that too a very simple one. Fine. So INH drug inhibits mycolic acid synthesis and it causes B6 deficiency. So again, it causes peripheral neuropathy. So what is the drug of choice which is used in peripheral neuropathy induced by INH? That is pyridoxine. This is also a very important pharmac question. Fine. How do you treat and prevent the peripheral neuropathy, psychosis, membrane loss which is occurring because of INH? That is by use of pyridoxine. Learned ho gaya beta? Right? Then rifampicin. It, please write down, it inhibits the RNA polymerase. Inhibits RNA polymerase or it inhibits the transcription. Rifampicin, remember, RR same. So it is safe in renal failure because it is secreted in bile. It is also the least toxic. Okay, side effects we will do. And it is also one of the DOCs for brucella. Doxycycline and rifampicin, they are the combined DOC for brucella. Rifampicin is an enzyme inducer. That is why if somebody is on warfarin, you replace it with heparin. If somebody is taking oral contraceptive, then beta, you have to advise to use other methods. Fine. So how will the question come? A lady was taking oral contraceptive pills and she was advised a drug. The oral contraceptive failed. Which is the anti-tubercular drug given to her? So that is the answer, rifampicin. Okay, repeat question hai, very much it has come. For the TB, remember the first line drugs, not S anymore, but since it is in that chart, we have to remember. Second line drugs, remember fluoroquinolones, and in injectables, better remember the name. Capreomycin, kanamycin, amikacin, streptol, linezolid, clofazimine, cycloserine, ethionamide, thioacetazone. Right, please remember this. Especially remember bedaquiline. You know, this is a recent drug, newer drug, and it inhibits the ATP synthase. Why it is important? Because number one, it is a newer drug. Number two, it is used in the various resistant cases. And third, it causes QT prolongation. Fine. Bedaquiline and delamide. These are the two drugs which you should remember the mechanism of action also. It inhibits the mycolic acid. Bedaquiline inhibits ATP synthase enzyme. Right? Now, this question beta, if anyone has TB and HIV, then first you have to give the anti-tubercular treatment. After 2 weeks, start the antiretroviral treatment. Fine. So if there is a patient of HIV, TB is there, the question will ask, what will you start first? Fine. Anti-tubercular treatment will be started first. Okay. Now coming to the side effects, everyone, which are very important, and I think you know it. You know it. Right, INH, we know peripheral neuropathy, jiske liye we are giving pyridoxine, important question. Right, it is hepatotoxic. Rifampicin, we know orange colored urine, the contact lenses are stained. Right, rifampicin is also used for leprosy. Right, this was the side effect. This is a use, and brucella, and this we have done. If somebody is on anti-HIV drug treatment and we have to give rifampicin, then we give him rifabutin. It is replaced. So these three probable questions you must know. What will happen if somebody is taking warfarin? What will you do? Because enzyme inducer hai rifampicin, we have to change it to heparin. Fine. Oral contraceptive question has also come. So please learn these three. Fine. Which is the most hepatotoxic? We know. E for ethambutol, E for eye. So eye, red green color blindness, avoid in children less than 6 years, or the question might say optic neuritis. S drug is totally avoided, the streptomycin in pregnancy. Why? Because nephrotoxic, ototoxic, and neuromuscular blockage can also occur. Fine. For the regimen, please remember this: 2HRZE plus 4HRE. If somebody is a newly diagnosed person, remember this regimen from the NTEP. And what is drug resistant? ठीक है, सिर्फ ये याद रखो. What is drug resistant? MDR, multi drug resistant, when it is resistant to both H and R. Right? XDR beta, when it is resistant to even the fluoroquinolones with H and R. Fine. And extensive XDR. See, this is XDR. If they ask you in question, if they ask you extensive, then beta H, R, fluoroquinolone resistant, and bedaquiline also now gone. Fine. So how do you treat all these drugs? You use the other drugs. That is why the name of the other drug is very important. Capreomycin, cyclosporin, ethionamide. These all you should know. Fine. Learnt bete? So where do I see the orange colored urine? 2 questions. Where do I see the orange colored urine? Jaldi se answer. Answer everyone. Orange colored urine. Okay. Very good. Which is the most hepatotoxic? Which is the most hepatotoxic? Jaldi, 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 quickly. After this, I will just have a look at the doubts so that we can answer it. Fine? Okay, very good. Z drug. And can you give Z drug in a pregnant female? Can you give Z drug in a pregnant female? Very good. Can you give Z drug in a pregnant female? Very good. Very good. Excellent. Which is safe in renal failure? Which anti-tubercular drug is safe in renal failure? Her. Very good, Dr. Sweetie. Excellent. What is the mechanism of action of INH? I know you all would be knowing the side effects because side effects पे question आता है. But beta, when you are doing tubercular drugs, anti-tubercular drugs, then 3 types of questions will come. 1, that chart. 2nd, mechanism of action. 3rd is your side effects. Side effects से ज़्यादा आता है, right? And 4th, of course, they can ask you about the MDR, the multi-drug resistant, the XDR. They can ask you that, okay? And regimens, do not waste your time in learning the regimens. Again, the regimens will be a bad day question. Fine. Okay, very good. So beta, this is I think a homework. Just learn the mechanism of action. I know आपको सब याद है, the side effects and that chart, right? But know this. Fine beta, rest everything is sorted. Okay, few questions which are recently added at the medical side of the exam. So let us just quickly do them. We don't have to do much. Fine. Just like ethambutol, ethionamide is also tuberculostatic. है ना, ये भी question है. Ethionamide is also one of the questions. Ethionamide is also hepatotoxic and it is tuberculostatic. Fine. And for thioacetazone, recent question at the medical side, you must just know it. Okay, that is why I am doing it at the end. Just know it. It is not given to the HIV patient. Why? Because it can lead to various severe skin problem. It can lead to the Steven-Johnson syndrome. Peeling of the skin, painful peeling of the skin might occur, especially in HIV. We never give this drug, thioacetazone. Okay, and bedaquiline and delamine, to I have already told. Okay, just have a look at the mechanism of action. Newer drugs hai, questions can be framed, but mostly the questions will come from the rifampicin, warfarin, OCPs, pregnancy, renal failure. These are the questions. Fine. From the mechanism of action, less questions are framed, but have a look if you know everything else. Done? Done, beta? Okay. Now let me just have a look at the questions. Hanji, for abhi just let us take 2 minutes break where I am looking at your questions and I will answer. Okay, last drug, beta, thioacetazone. See, beta, thioacetazone, please note kar lo. It is also static drug. It is not given to the HIV. Why? Because it has Steven-Johnson syndrome like thing. So HIV mein nahi dete. Recent question hai. Okay? Okay. And one more thing, rifabutin हमने बताया था, whenever there is an HIV patient, we will shift to the rifabutin. Why? It is having less action against the TB, but it is more active against the MAC. Right? It is a less inducer of microsomal enzymes. And like rifampicin, no renal adjustment is required. Side effects are uveitis and polyarthralgia. Okay, so rifabutin, just know one context where we have replaced rifampicin with rifabutin. Fine? Okay. Otherwise, orange colored urine, contact lens, eye blindness, red-green eye blindness or optic neuritis, these are the things which are going to come in the side effects. Fine? And your, what do we give in the INH-induced peripheral neuropathy? Very recent repeat question. Okay. Now, please, you note, I am just looking at the doubts. Okay, Dr. Dipesh, XDR TB में fluoroquinolones ही है बेटा. See, HR and fluoroquinolones and the other drugs. Any other newer drugs. Okay, either linezolid or bedaquiline, any drug. Still, I will confirm from the pharmac faculty if aminoglycosides are there. I will confirm and tell you. Okay. As such, it is not. Any other question, beta? Dr. Dipesh again, same question. Okay, beta, I'll just let you know about this. As far as I have a table in front of me, so that table says fluoroquinolone. And then later in the extensive, bedaquiline and linezolid also. Okay. Dr. Rajveer Singh done. Maybe beta kuch mistake hua hai, so please make a change in that. Okay. Now have you understood? Just remember that diagram. The upper lobe ka lower part and lower ka upper part. These are the two most common side. Out of this, if they give you to mark, then you mark the first one. Remember the diagram I made. Okay, just remember it like this. This is the first one. This is the second one which you have to mark. And at the apex, if it is secondary TB. Dr. Shubhangi, आप ही change कर लो एक बार. Yes, Dr. Shubhangi, actually basal part भी हो सकता है. See, secondary TB can occur anywhere. So it can be anywhere, but this is the site which, if it is present, we suspect that it is secondary TB. Fine? Acha, one more question. You all know that question. That is why I have not done. Miliary TB is hematogenous spread of the TB. You know, ये easy question आता है. So don't make a mistake in this. Dr. Saleha, breath sounds. Beta, I think for INI it is important, but not for NEET. But you can never judge and, you know, tell. So if you get time, then you can do the breath sounds. Otherwise, beta, the bronchial vesicular, they are not, never being asked. Never being asked. Actually, see, what we speak, the teachers, you know, what we tell you to study is based upon what has been coming and what can come. Like I told you, bedaquiline is a newer drug. So this, you know, mechanism of action can come. So learn kar lo. So this is how we predict things. Bronchial sound has never come. You know, breath sounds, they've never come. INI maybe. Okay. Okay, Dr. Rajveer Singh, again, आपका doubt बेटा clear करो. यही है जो है, इसको you note it. Okay. Okay, Dr. Muskan, I will explain this to you at the end. FEV1 clear हो गया बेटा. Forced expiratory, expiratory, not respiratory, expiratory. It is during expiration, not inspiration. Dr. Ayush, I think Pharmac sir has told tiotropium, or basically you should know the group. ठीक है, इपेट्रोपियम है या टियोट्रोपियम है, whatever is there in your pharmacology notes, please write it. But exam में टियोट्रोपियम नहीं आता है, right? इपेट्रोपियम आता है. So इपेट्रोपियम is a question which you should know. Fine. Okay. AHI beta, AHI is per hour. Per hour. It is, sorry, I've written per day. It is per hour. Please correct it. Done beta? Okay, very good. Now few small things left. Very small, but little bit important because they are the pathology of the respiratory system. Okay. Okay, beta. Very important. From pathology, pleural effusion, transudate, exudate, very important. Fine. So I want every one of you to... Yes, beta. Yes, Dr. Yogita. They are the ILD and fibrosis. They all are intrinsic. है ना? Intrinsic माने lung is sad. Simple. Now pleural effusion, everyone. Remember transudate and exudate. Very important. Very important. मतलब आता ही है in the pathology part. So you must know the light criteria. In light criteria, just know exu माने X है वो. मतलब it is having extra. Right? So it is always everything is high. Whenever you get confused, bete, exudate will have everything high. Pleural protein more than 3 is present in exudate. Then LDH, the pleural LDH, the ratio is also more than the 0.6 of serum LDH. Hana, this ratio is also more. So basically pleural LDH, pleural protein is more in exudative. Right? Pleural LDH is more than 2/3 of the serum LDH. This is the Lights criteria. Lights criteria क्या कहता है? Everything is more. The pleural protein, the pleural LDH, everything is more. Fine? Okay. Next, even you know the leukocytes, the cholesterol, the cells, they are more in the exudate. Fine? But maybe glucose is low. The only thing which might be low is glucose. Fine. Examples are always asked. Beta, exudative में क्या होगा? Exudative is extra. Extra मतलब something wrong happened. ठीक है? Extra मतलब something wrong has happened, like in inflammation, extra things happen. Malignancy, extra thing happens. TB, infection, extra is there. Pneumonia, anything. Or Meek syndrome. Meek syndrome is what? It is pleural effusion or even ascites with ovarian cancer. So ovarian cancer can be there. Even rheumatoid arthritis is your exudative. Fine. Transudative, please remember, nothing wrong with the membrane. Inflammation nahi hai, kuch nahi hai, right? Malignancy nahi hai, everything is fine, but the body overall is bad. When the overall body is bad, nephrotic syndrome, cirrhosis, liver is problem, lung is showing the effusion, kidney is a problem, the lungs show the problem, right? So when there is the problem is in the whole of the body, right, then it is transudative. Exudative means inflammation, right? Please remember this, malignancy, TB. Fine beta. And CHF, congestive heart failure, hypothyroidism, pulmonary edema, right? So these all examples, they should be on your tips. So two things from this table: exudative, everything extra, protein extra, LDH extra, the lights criteria is also extra, cholesterol, specific gravity, cells, everything extra, glucose may be low, right? And this is also a question, bete, where in which all types of pleural effusion you find low glucose. Today we got this in our WhatsApp group, this particular doubt. So beta, glucose is less in TB. I told you, exudative, it is less in rheumatoid arthritis cases and malignancy. Remember these three, right? Especially TB, especially RA. So the question which I got in my WhatsApp group was, which of the following pleural effusion has less glucose? TB, RA, both, or whatever. So answer will be both. Fine, everyone? Okay. Now, please see this X-ray, everyone. You get this X-ray, suppose. Can you see this X-ray? Right? You have to diagnose. Case kya hai ye? So you know, bete, normal X-ray kaisa hoga? Normal X-ray will be equal on both sides. And you can easily know the various markings also on that X-ray, right? And you can make out the heart also in that X-ray. In this particular X-ray, one side is white. White matlab there is fluid present. Now this particular so that means it is a case of pleural effusion. Fluid is present. Fine, everyone. Low glucose, I have done with you. Malignancy, TB, RA, empyema chhod do, it won't come. If they say it has more amylase, lipase, pancreatitis, right? So again, this was a question in one of the exam. What is the marker for pancreatitis? Amylase is high, right? Chylothorax means milky white. It has triglycerides. And when do I see anything chylothyroids? Whenever there is triglycerides more than 100 mg per deciliter. Fine, everyone? So X-ray can also come. Now, this is the question which was your last year question. Let's read it. A patient complains of shortness of breath and coughing. Pleural effusion is there. He has given you the diagnosis. On standing, pleural fluid accumulates around cardiac recess, costomedial recess, costodiaphragm recess, oblique fissure. What will be the answer? What will be the answer, everyone? Okay, Dr. Aryan, then we will go with it. No problem. Different books will say different. So that is why I'm saying whatever is there in your pharmac. So if your aminoglycosides are there, do it. But beta, as far as I've seen the questions, fluoroquinolones pe hi hota hai. Okay? So if it is in your notes, we will, accept it and we will learn it. Very good. इसको क्या बोलते हैं? Blunting of CP angle, costophrenic angle. See, bete, this will be the, whenever the person stands, where will the fluid go because of gravity? Down. So what will happen to the costophrenic angle? Blunting will occur and it will go to the costodiaphragm recess. Fine. Obviously, you will stand up, it will go down. Right? Now in this beta, supine, X-ray can also come of one side. Right? So of one side, suppose I twist this X-ray, right? as water will move, the X-ray will be there. So fine. So what you will see, if suppose I make this person turn to one side and then I shoot the X-ray, then beta all the water will collect to this side. Suppose I tell this person to turn this side. So beta, what will happen around here? The lung will be almost like normal, but here all the fluid will accumulate. Right? So that will, don't panic if you see such kind of an X-ray. That just means a person was having fluid and I told him to lie on one side. Fine. And the water will go to the side where that person has tilted. Fine. So don't worry, X-ray you can easily make out. Fine. Next is, very good. Very good everyone. All of you have answered right. Beta wo HI wala kar liya. I think in this particular PDF I have written it as day. It is not day, it is hour. Okay. Okay. Most common cause of pulmonary embolism. Repeat question, repeat question. Deep vein thrombosis, lower leg, calf vein. Why it happens? Because of Warshaw's triad. Fine. It happens in prolonged immobilization. Pulmonary embolism is the most common cause of preventable death in hospitalized patients. Question है. Now, this is something which is important, factor 5 Ladine. In this, it is the most common congenital hypercoagulable state. When we revise blood, we will be doing the factor 5 Ladine. What happens if it is resistant to the action of APC, activated protein C? The clot, the fibrin clot which has been formed, it will not break. Fibrinolysin doesn't occur. Lysing doesn't occur. So wherever in the body the clot was formed, it will be formed. It will not be broken down. And if God forbid it is in the leg, then embolism will occur. Fine. Now beta, how will the question come to you? 75-year-old man underwent surgery. 8th day, he had sudden onset dyspnea. अब sudden onset dyspnea का one I told you was ARDS. Beta, ARDS is a very bad state, है ना? Pulmonary edema is all. The pulmonary embolism is also very life-threatening, right? But the good news is 75% is asymptomatic. You will not even know if someone has it. Right? So sudden onset dyspnea, especially after a surgery, especially after childbirth, right? Serena Williams had it. Fine, beta. So what is the gold standard? The CT pulmonary angiography, not just CT. Not just CT, angiography, pulmonary angiography. Repeat question, beta. We can do the D-dimer test. What is D-dimer? ये जो clot बना था बेटा, this clot, right? In our body, in a normal person body, this clot gets broken down, right? But if someone is having, suppose DIC, disseminated intravascular coagulopathy, or someone is having pulmonary embolism, in these cases there is hypercoagulable states, right? And this clot is formed, is broken, is formed again, some clots are formed, again broken. So what is D-dimer? D-dimer is the end product of the fibrin clot that is breaking down. Okay, it is the fibrin disintegrating product, that is FDP. And D-dimer test, it is very sensitive test, right? But it is not specific. It will be positive in any state where we are having a lot of hyper formation of the clots. Right, so yes, pulmonary embolism, DIC, DVT cases, we will see the rise in D-dimer, even in COVID cases. So it is not very specific for this, it is pulmonary embolism. Gold standard is CT pulmonary angiography. In the echocardiography, we can see the McConnell sign, just know the name. Nobody will give you what it is and what it means, right? Next. If there is a surgery If there is a surgery and there is a long recovery time, how will you prevent the formation of pulmonary edema, right? So the first thing is early mobilization. इसको याद कर लो बेटा, this is an important question. How will you prevent pulmonary embolism? Early mobilization. After C-section, another next day you have to get up. After every surgery, if it is a small to a moderate surgery, within 2 days you need to get up, right? If it is a very extreme surgery, then at least some movement of the legs has to be done by the patient. Fine. Or you can use the pneumatic compression stock. First is early mobilization. You will not write pneumatic compression socks. Early mobilization is the key. Fine. This I have already done. 70 to 75% are asymptomatic. Most common symptom is dyspnea. Most common sign is tachypnea. Sign and symptom, you all know it is little different. Chest x-ray, everyone. 3 signs, very important. Westermarck, Palla sign, Hampton's hump. Westermarck sign is the focal oligemia. Focal oligemia, wherever that embolism is there, you are not going to get any blood supply. Now there is one question, beta. Ventilation perfusion ratio is going to be infinite when perfusion is 0. Now can this be a case of that embolism? Yes. So when the denominator is 0, ventilation perfusion becomes, just let me open it beta once. Yes, Dr. Saleha, I will teach you. Just wait. Fine. So ventilation perfusion ratio, I think this was a question yesterday. So ventilation perfusion ratio is infinite when the perfusion is 0, when there is some embolism. Ventilation perfusion ratio is 0 when ventilation is 0. Ventilation can be 0 when there is any foreign body obstruction. There is no air. समझना है. Just apply mind. Denominator 0 होगा, infinite. Numerator 0 होगा, it will be, the answer will be 0. Fine. So just apply the mind. You get few conditions. Apply करो. कहाँ perfusion होगा? Perfusion माने blood. Ventilation मतलब air. So which all conditions will stop my air? Which all conditions will, stop the blood flow? And, mark the answer. Fine, everyone. So this is the Westermarck sign. Palla sign. This is dilated. Learn करना है. Right descending pulmonary artery. Hampton's hump. It is the wedge-shaped opacity above the diaphragm. Right? This all has to be on your tips, bete. ये देखो. Okay, I don't think you can see this particular diagram, but just see, it is this wedge-shaped deformity which is there. This is your Hampton's hump. Then this is dilated right side pulmonary artery. And the Palla sign you have seen, Westermarck means there is wherever that embolism is there, then there at that particular portion you are not going to have any, you are going to have oligemia. Fine. So that are the 3 signs. Okay, done. Please note. Fine. Either there will be a question where they will just write these terminologies and then you would have to diagnose, so you can easily diagnose. Okay, ECG, repeat with me. S1, Q3, T3. S1, Q3, T3. S1, Q3, T3. That is the question. In the first lead, deep S wave. Third lead में Q wave. Third lead में inverted T wave. That is what you see. But if they ask you the most common sign on ECG, then it won't be S1, Q3, T3, it will be sinus tachycardia. Sinus tachycardia. Fine. D-dimer is not diagnostic. Okay, I have already told you this. If there is early onset dyspnea, beta, 2 questions come. So you have to find out. One is pulmonary embolism, other is fat embolism. So what will be the catch points? Pulmonary embolism may immobilization after surgery, after giving birth, right? So immobilization will be a factor. A patient had RTA. He was operated for the abdominal injuries and he was on bed rest for 1 month. Then he developed early onset dyspnea. It is pulmonary embolism. Done? Right? Next, a patient of RTA had fractures. His femur was fractured and he developed on the 3rd, 4th, 5th, whatever day, he developed dyspnea. Then bete, it cannot be pulmonary embolism if it has not been specified. Then क्या आंसर करेंगे? Fat embolism. Fracture of long bone. Done beta? So these two questions very carefully. Catch points pakdo beta. Every question has a catch point. Right? Everything. And in your exam, I'm going to really tell you a very big thing. Questions will not be on values. Right? Like tidal volume. चलो easy है 500 सबको आता है ठीक है ना बट ऑन द कैपेसिटीज 4.2 है 3.6 है 7 है व्हाट है नो दे आर नाउ नॉट फोकसिंग ऑन द वैल्यूज दे आर फोकसिंग ऑन डू यू नो व्हाट इज FRC डू यू नो व्हाट इज रेजिडुअल वॉल्यूम नॉर्मल में है फुल एक्सपिरेशन में है डू यू नो व्हाट इज द मिनिमल वॉल्यूम right? So they are focusing now on the the knowledge and not on the numbers. Sirf aapko values maybe in implants you learn. Fine. So if you are forgetting the values, do not panic. Don't worry. Right? So from today onwards, nobody will worry if you don't remember much of the values of any subject because paper mein nahi aata hai. You have seen the papers. Right? It is not coming. They are focusing on concepts. So concept you should know. Fine. Palla sign. Enlarged right descending pulmonary artery. See here everyone. This one. This won't come to you. This X-ray will not come to you. How will it come to you? See, they will give this X-ray and then they will write dilated something is there. They will write focal oligemia and then you will be asked which sign is this, where do I see it? You are not going to get an X-ray ke bhai read karo. No, I don't think so. Fine. Okay, pneumonia everyone. Quickly karte hain. We all know it is a lower respiratory tract infection. Lobar, lobular or atypical pneumonia. Lobar pneumonia, remember it is pneumococcal and Klebsiella. Right? Very important points I am telling you, bete. Long question, 1 point and you will be able to answer. Fine. Lobar pneumonia, pneumococcal, Klebsiella. Klebsiella mein there is red currant jelly sputum. Finish question over. Big question with an X-ray and there is one line. Red currant jelly sputum. Klebsiella. Fried Landers bacterium. Klebsiella. Right. Lobar pneumonia with cavitation. It is Klebsiella. Lobar pneumonia without cavitation or the most common one is pneumococcal. Fine. And this is your pathology. This is your pathology beta. What are the stages of pneumonia? So just say with me CRGR. ठीक है यही क्वेश्चन आया है once आया है just once it has come. CRGR. What are the various stages in pneumonia? Congestion, red hepatization, gray hepatization, resolution. CRGR. If they ask you days, remember congestion is 1 to 2 days and then you keep on multiplying by 2. Red hepatization is multiplied by 2, 2 to 4. Gray hepatization again multiply by 2, 4 to 8. And resolution is 9th day. Fine. So remember CRGR. Once this question has come, please arrange the various stages of pneumonia. So CRG are days, also you must know. Okay, lobular pneumonia occurs in staph and it has cavitation. Atypical pneumonia को बोलते हैं walking pneumonia. The patient is walking. Mycoplasma is the most common cause of atypical pneumonia. Coxella burnetii, they all can cause anything atypical, which is not pneumococcal, staph, Klebsiella. Fine? Okay. Next, pneumococcal and Klebsiella. Remember, pneumococcal ends with L, so it occurs in the lower lobe. Right? L loves L. Always. Always. This is the rule in medicine and physiology. L loves L. Right? Klebsiella ends with A. A is the first alphabet, so upper lobe. In pneumococcal, cavitation is present. In cavitation is absent. Klebsiella, it is present. And here red currant jelly sputum. Please remember this term. Fine? Okay. Then most common community acquired pneumonia is by strep pneumoniae or pneumococcal. Right? This is also a question. What is the most common cause of round pneumonia? Round pneumonia क्या होता है बेटा? It is present in the children wherein round, you can see on the x-rays. Fine. So most common round pneumonia. Fine. Nosocomial pneumonia, again this question has come. Okay. Next, nosocomial pneumonia occurs within 48 hours or 2 days of hospitalization. Right? 2 days of hospitalization or 48 hours. Repeat question. Most commonly it is due to the staph. Okay. Ventilator associated, most common is due to Pseudomonas. And this has come in the question once. Okay, the ventilator associated pneumonia, not in our question, but in one of the medical exams. So VAP, now they said, okay, people know that Pseudomonas are the most common. Do they know it is caused by Acinetobacter also? So Acinetobacter also you learn, but that is second most common. Most common in multi-drug resistant VAP is Pseudomonas. Most common in non-MDR VAP is pneumococcal. Fine. Pseudomonas is also most common infection in burns patient. Right. Most common in AIDS, TB. Most common in burns, Pseudomonas. Fine. Okay. Then Legionella disease. Legionnaire's disease. What happens? There is a person. He went on a cruise. He went to a hotel. He went to a hospital. After 10 days, or he had been drinking from a faulty water tank. He went on a cruise. After 10 days, this will be the story. After 10 days, diarrhea, pneumonia, and altered, senses occurs. Finish. This is Legionella. Because in this beta, we have pneumonia, diarrhea, and hyponatremia can also occur, but pneumonia and diarrhea is the history. Fine. Next, pneumocystitis jerovicae. We all know CD4 count, right? In this also, bilateral diffuse infiltration will be there. If they give you a history of bird handler, there is a person who is working with the parrots, then psittacosis will cause pneumonia. Right? Bats and rabbits, I don't think they are much important, but still let us do them. Bats is histoplasma, rabbit is Francisella. And this I think pata rehta hai, Francisella tularensis is something related to rabbit. Fright, Landers, bacteria, Klebsiella I have told you. AIDS mein, they ask you what is the most common pneumonia. Our mind goes to pneumocystis jerovicae. Pneumonia pucha hai. They are not asking opportunistic infection. They are asking what is the most common cause of pneumonia. Then it is pneumococcus only. If they give you the CD4 count, then it is this. Right? In the COPD-H influenza, if they give you a history of goat or sheep handling, then Coxella. Right? Somehow, goat and Coxella go together, and tularensis goes with the bat. Francisella, somehow, So you don't need to ratify it. Fine? Okay. Clubbing beta. Please remember clubbing for clubbing. Drumstick fingers. Positive Shamroth test. See beta, do like this. Do like this. I'll just show you. This is the Shamroth test. When you do like this, in normal cases, we will have this space. Correct? But in the clubbed, above space is not there. This kind of a thing is there. This is known as the Shamroth window test. This is done for the drumstick fingers. Done? Okay. Next, what are the causes? Very important. Cystic fibrosis, we did today. We did it? Right. Then lung abscess. First, let us do all the lung things. Lung cancer, lung fibrosis, bronchiectasis. The mnemonic is clubbing only. And CHD, cyanotic heart diseases. We see it in the TOF. Right. Tetralogy of Fallot, cirrhosis, very important. And infective endocarditis. And if they give you GIT, ulcerative colitis. Or celiac disease also sometimes we see. In TB, the chances are less, but it can be there. Right? But if suppose TB is in which of the following clubbing is not seen, and you get all of these and you get TB, then you can mark TB. Okay. So this is how the hand looks. These are not spoon fingers. This is not Koilonychia which you see in the IDA. This is drumstick fingers, just like drumstick. Right? Distorted angle. So know the causes of clubbing beta, very important. Then Carter-Jenner syndrome. Carter-Jenner syndrome, which I did, Young syndrome and Carter-Jenner. So Carter-Jenner syndrome is immotile ciliary syndrome. In this cilia, they become immotile. So during embryogenesis, we get situs inversus. What is situs inversus? Heart, which is usually little bit on the left side, is on the right side. But it is absolutely normal heart, and this was the question. In Carter-Jenner, are they having any heart abnormality? Yes, space hai, place change hai, heart is normal. In respiratory, we see bronchiectasis, sinusitis, and infertility because sperms also the count is reduced. Right? Next is good pasture syndrome. Very important. Ramu has bleeding from in the urine and blood in the sputum. Hematuria, hemoptosis together. There is no other disease. It is only good pasture. Fine. But here you have to know certain more important points. It is autoimmune. हाँ डॉक्टर आर्यन वो एक ऑल्टरनेट डेफिनेशन है, वो एक ऑल्टरनेट डेफिनेशन है, बट क्वेश्चन आता है 48 आवर्स में. 90 डे ऑफ डिस्चार्ज वाला भी एक डेफिनेशन है कि इफ विद इन 90 days ऑफ डिस्चार्ज द निमोनिया डेवलप्स, देन इट इज अ हॉस्पिटल अक्वायर्ड, इट कैन बी कंसिडर्ड. बट क्वेश्चन क्या आता है? 48 आवर्स, 2 days. फाइन. Autoimmune antibody against the glomerular, the basement membrane, anti-GBM. Right? So we have the hematuria, hemoptosis. One more thing, we have crescentric changes, and this we see in non-smoker. So in this, what will be the case? Ramu, non-smoker, still having blood in sputum, urine also having. Fine. This is more common in males if it is occurring early, and if it is occurring later, then equal hota hai. And because it is having the glomerular problem, dysmorphic RBC and RBC cast will be seen. Fine. Okay. PAP, pulmonary alveolar proteinosis, it is just intraalveolar deposition of surfactant. Neonatal में fatal होता है बेटा, baby है fatal है, adults में it is not that fatal, neonates में it is autosomal recessive. Fine. Coming to another pathology topic, sarcoidosis. Few very important points about it. ठीक है? So sarcoidosis, you all know it is a multi-system disease, but most common organ which is involved in sarcoidosis is lungs. Learn करो इसे, lungs में होता है क्योंकि हम lungs में पढ़ रहे हैं. We are reading, you know, with Dr. Jasmine, you read all of this in lungs. So sarcoidosis, most common organ is lungs. ठीक है? We'll come to these syndromes later. Right? First, let us do this. This is a non-caseating granuloma. Sarcoidosis is a non-caseating granuloma more than the caseating. Very important question, repeat question. In sarcoidosis, repeat question beta, you see two bodies, asteroid bodies, Schaumann bodies. SS, दोनों में S है, दोनों ही sarcoidosis में है. Right? So they will give you a histological picture and they will say कि भाई asteroid body है, Schaumann body है. Now tell what is the diagnosis. So you don't need to become a pathologist. Don't look at the image, look at the words given. Fine, easy आएगा paper. Next, Kevin test. Old test है, but it is done for sarcoidosis. Now it is not done. So what are the tests now we do? Increase ACE enzyme, increase calcium, hypercalcemia, metastatic calcification occurs in sarcoidosis. Important question. Which of the following disease has hypercalcemia? Fine. For this, you know, normal CD4 to CD8 ratio is 2:1. Sarcoidosis में it becomes 15:1. Fine. Okay. Bilateral hilar lymphadenopathy, eggshell calcification, and Garland's triad. These are important cue points for sarcoidosis. Right? Bilateral hilar lymphadenopathy, eggshell classification. I think you can also see in silicosis also. Right? So whenever you get a question, just see कि भाई क्या बोला जा रहा है. Sarcoidosis के बारे में बात है, silicosis के बारे में बात है. Right? They will give you the hint. Fine. We do a gallium-67 scan for this, which has lambda sign, panda sign. No need to know anything about it. Just know this much. So beta sarcoidosis, jaldi se karte hain. 2 more topics are left and then we are done. See, this is all pathology. This is not medicine. But you should know about it. Fine. And please note ke bhai, if we have to diagnose it, then we have to do a biopsy. Fine. And confirm करने के लिए तो we have to do a biopsy. Fine. So bilateral hilar lymphadenopathy, eggshell calcification, Garland triad, lambda panda gallium-67 scan, increase calcium, KVM test, asteroid body, Schaumann body, non-caseating granuloma. This you should know. 2 syndromes beta, please revise. Herefordshire syndrome, है ना, ये बहुत important है. I think it comes in your OP also, wherein you have uveitis and parotid size is increased, fever is there, facial palsy is there, right? And this is also from the Lofgren syndrome. So Lofgren syndrome, these are the 2 syndromes which you must learn. So लिख लो, learn कर लेना, ठीक है? Okay, next, very recent favorite topic. I don't want you to mess this up, so that is why I am writing it. Fine. So silicosis. Silicosis, it is most common occupational disease in the world. Grinder's disease, minor disease, glass industry. Silica कहाँ use होता है? Glass industry. And yes, eggshell classification, hilar lymphadenopathy. So beta, if the question is, where do you see eggshell calcification? Silicosis, sarcoidosis, both. So both. है ना? Okay. Next is asbestosis. I will do pneumoconiosis later. First, I am just making you learn. Silicosis में याद हो गया. tosses. Base tosses. So that means this is occurring at a lower lobe. Right? This is the only occupational disease which is occurring at lower lobe. Base आता है ना उसके name में, base आता है. Now the question, silicosis occurs at the upper lobe. Understood? So asbestosis base आता है. Asbestosis is the occupational disease which is associated with the carcinomas. ठीक है, asbestosis carcinoma से होती है, which is the most common adenocarcinoma, but most specific is mesothelioma. If they ask you very specifically, malignant mesothelioma. बेटा important question है. Asbestosis में asbestos body and ferruginous bodies are seen. That's it. And most common manifestation in asbestosis is pleural plaque, and this is one occupational disease which leads to adenocarcinoma or any kind of carcinoma. Most specific is mesothelioma. याद हो गया? Bodies, ferruginous bodies, asbestos body, क्योंकि iron is there. For iron we use the Prussian blue stain. Fine. So important. Asbestosis is very important. Coal workers, anthracosis, pneumoconiosis. They will have dust cells. Right. So silicosis में क्या था? Eggshell calcification, hilar lymphadenopathy. Asbestosis में we had pleural plaque, asbestos and ferruginous bodies. And pneumoconiosis या anthracosis में dust cells. Fine. Done. Just names will come. Bagasosis, sugar cane industry में जो work करते हैं, they have this occupational disease. Piscinosis, cotton dust. अब एक और question आता है. This is the Monday chest syndrome. This is occurring after, the first day of work, when again, the worker goes, he's having chest tightness. So Monday chest syndrome. This occurs in cotton industry, textile industry, especially during milling and processing. So beta, this question has come. Out of the following occupational, which is Monday chest syndrome? Right, sidrosis, iron, we all know that. Farmer lung, hay, है ना? Then please remember, stenosis you will answer. Right, so beta, asbestosis, silicosis, anthracosis, bagasosis, piscinosis. You must know. Direct question will come. Do not make a mistake. Fine. Last topic everyone, lung cancer. Lung cancer में few important points I am going to tell you. Most common in the world is ACC, which is present in the non-smoker, which is present in the females, which is present in the young patients. Right? And this shows lung to lung metastasis, from right lung to left lung. So most common in the world, ACC. Right? Paraneoplastic matlab what all can occur with this neoplasm. So osteoarthropathy and this can occur, but this is not that important. ठीक है? जो important है, we will learn it. It is the most common lung cancer occurring in the non-smoker. Learn करते जाओ. Right? However, most common in India is the squamous cell carcinoma, which involves gene P53. Question beta. It is also related to Pancoast murmur. It shows cytokeratin pearls. And even this is a question. Which paraneoplastic thing you see with it? Hypercalcemia. And it is because of parathormone related peptide. And this is most common in smokers. Okay, these are the important points. So non-smokers ACC, smokers SCC, which has keratin pearls SCC, which has hypercalcemia SCC. Right? Next, small cell carcinoma or oat cell carcinoma. Few important points about it. it is most responsive to chemotherapy, radiotherapy. Right. Next, it is one which is associated with the Lambert-Eaton syndrome. It, in the histology, iska histology important hai. What is the histology? We see the salt and pepper effect and a special effect, azopardy effect. Azopardy effect is blue blood vessels. Basophilic staining occurs. Whereas salt and pepper effect, matlab cells have less cytoplasm, less nuclei. Fine. Usually if they ask you what is the most common cancers, so wo to Mets hai. Right? But if they ask you in the smoker, in India, in world, then you should be able to answer. Fine? Okay. Done. V by Q also done. Okay. Pulmonary artery hypertension. Please remember, all the pressure, when it exceeds 25 mm Hg, we start feeling the symptoms. So this is one question which has come. Right, less than 18 non-cardiogenic pulmonary edema, more than 18 pulmonary cardiogenic pulmonary edema, more than 25 we see the effects of pulmonary artery hypertension. Finish. Horner syndrome, beta, you must know, it is from your oral pathology. You must know what is happening in it. Maple is happening, meiosis, anhydrosis, ptosis, inophthalmos, and loss of ciliospinal reflex. Fine. Horner syndrome, why it is important? Because it occurs due to compression by the Pancoast tumor. Pancoast tumor ka cause kaun tha? SCC. Fine. Very good. Okay. Now, causes of pneumoconiosis. Please note, organic dust, inorganic dust, chemical fumes are a cause of pneumoconiosis, but smoking is not. So, bas just ye remember karna hai, smoking is not a cause of pneumoconiosis. Fine? Okay. Farmer lung, you must know, it is due to the thermoactinomyces sacchari vulgaris or viridis. Hay se hota hai, right? Aspergillosis, please note, it is not contagious. In the lung, it is by A. fumigatus, and if it is otitis externa, niger. Drug of choice, if it is not invasive, voriconazole. If it is invasive, amphotericin B. Right? Very important 2 questions you must know. Pneumothorax. कुछ नहीं है. अगर idiopathic है, it will occur in a tall individual. Right? It will occur in a tall individual, male who's a smoker, and or it may occur in a disease or a trauma case. Right? So this will be the X-ray. See this X-ray, everyone. Can you see this X-ray? This side and this side, they are different. We can see the chest markings here. But here I cannot make out any vessels, anything, any markings. Right? That means this side has more air. Correct? This side has more air, and this is a pneumothorax case. Fine. Chest, see beta, what will happen? Air is more, so blackness is more. If water is there, it will become white. Hana? If air is more, the X-ray will become black. Plus the chest markings, the lung markings of the vessels and everything will not be there. Okay, so this is pneumothorax. How do you treat it? You do it the 5th intercostal space, right? And the second one, whichever the surgery sir has told, I think surgery sir has told 5th. So that is what we will answer. Fine. Very easy question. Most common cause of stridor in children, foreign body obstruction. For this, what do? You do the Heimlich maneuver. Heimlich maneuver क्या होता है? You have to push the abdomen up and in and up, and then the thing can come out. Fine. So beta, pleural effusion का X-ray, pulmonary edema का X-ray, pneumothorax का X-ray. Keep in mind Westermarck, Palla, Hampton sign, this sign, please keep in mind. Fine. So beta, this is all for the respiratory system, pharmac medicine and patho and medicine. Now let us rest. I have microbiology with me, but I think it's very late, so we should all rest now. Any doubts which you have, fine, just message on the group or message on the YouTube. It's okay. I will see and I will answer. Fine. And please make that change बेटा. AHI में अगर day लिखा है इस वाले PDF में, it is per hour. ठीक है? Make a change in it. Okay. Bye bye. Sayonara बेटा. So respiratory system अब गलत नहीं करना है. ठीक है? So that is one promise. You have to do it right. Microbiology is left. वो आप खुद करना पड़ेगा. Acid fast, mycolic acid, Zn staining. What happens? How does Zn staining looks? So this is very important. है ना? So blue background, red bacteria. Not vice versa. Fine. So Zn staining कैसे करते हैं? And carbofuscin, H2SO4, methylene blue. What happens to it? LJ media याद रखना है. BCG is the vaccine, right? I'm just repeating, just keep on doing it. BCG is the vaccine which you should know. M. leprae cigar shaped arrangement. It is known as Hansen's disease. It cannot be cultured in any media. So Koch postulate follow नहीं करता है. M. leprae is grown in the armadillo footpad, right? Lepra reaction. Please remember lepra reaction. Lepra reaction 1 is type 4 hypersensitivity. 5 बनाना है. 1 plus 4, 2 plus 3. So 1 is 4, 5. 2 is 3 hypersensitivity reaction. That is the question which comes. And drug of choice for lepra reaction is steroids. ठीक है? Done. So this is what I have tried my best to finish your pathology, pharmacology also. Questions will come from this. Questions cannot. Acha, one more thing is left. I think pleural effusion के लिए where do you make the drainage thing? It is at the 7th intercostal, right? Okay. Very good. So now please do not make mistake in the respiratory system. Very easy. ARDS क्या है? Asthma क्या है? Asbestosis base पे होता है, right? Sarcoidosis lung में होता है. Very important. Clubbing कहाँ होता है? These all are very important. Pneumonia, right? Very important, everyone. Please do very nicely. Transudate, exudate, 100% question. Lights criteria, 100% question. Okay? Very good, Dr. Sathitha. Very good. Good night. Thank you, everyone. Please go. Please go, relax, and then study again. Right? We will meet day after tomorrow for renal system. In renal system, 3 things I will cover. Physiology, important questions only. And acid base, medicine, and diuretics. Okay? Because one question has to come from diuretics. Come what may. ओके डॉक्टर शिवानी इसको पीडीएफ नहीं दे सकते हैं. ठीक है? पीडीएफ नहीं दे सकते हैं बिकॉज ऑफ सम इश्यूज. हाँ डॉक्टर शिवानी वो ऐड किया है. सो उसको वो मैं आपको SRK पे डाल दूंगी. ठीक है? उसको क्रॉप करके डाल देंगे. एनी अदर डाउट बेटे? ऑल दोज हु हैव डाउट स्टे, अदरवाइज गो. रेस्पिरेटरी सिस्टम इज गुड नाउ. Is it good? Are you confident? Can you answer any question about bronchial asthma? Salbutamol, terbutaline, salmeterol, formoterol. Right? Even now I also know the pharmacology. Right? Little bit. Not full, but little bit I know thanks to all of you. Okay, beta. Okay, bye, beta. Very good. Good night. डॉक्टर आर्यन ऑक्यूपेशनल डिजीज का ना आई हैव गिवन यू द नोट्स, है ना? SRK पे अटैच भी किए थे, ग्रुप पे भी दिए थे. इफ यू ऑल हैव और नॉट, राइट? नोट्स दिए थे ना ऑक्यूपेशनल के बेटा. ऑक्यूपेशनल पे हमेशा क्वेश्चन आ ही जाता है. ठीक है? तो उसे हमें पढ़ना नहीं है, वो पैथो में होता है. बट ये क्वेश्चंस होते हैं जो एग्जामिनर वांट्स यू टू आंसर. ही थिंक्स यू नो इट सिंस योर 12th. Okay, beta. Go, beta. Everyone, please leave. I will also leave in a while. You please go. I have to wait for any doubts. Please leave. Everyone, please go. Please leave. I don't mind if you leave. Go, bete. Please go. Anybody who has doubt, any one of you who wants to talk about anything in life, you can tell me, call me, or even right now we can talk. No problem. Rest everyone, please leave, bete. डॉक्टर आर्यन दिए नोट्स बेटा, मैंने ही दिए हैं. कोई बात नहीं, आई विल अटैच दिस. ओके, आई विल अटैच दिस. लंग कैंसर एंड ये का आई विल अटैच. डोंट वरी. Anyone who has any doubt, please tell me. I will wait for the next 5 minutes. Anybody wants to ask anything, please ask. It's okay, Dr. Rahul. I know you are studying late हो गए तो कोई बात नहीं. कोई sorry नहीं है बेटा. See, it is we all are working for your success. You are working for your success, and whatever benefit you want to take from these lectures, take it, and rest. If you are comfortable, don't even attend. It's okay. If you know the subject, if you know this subject very nicely, then don't attend and waste your time. I don't want you to attend unnecessarily and waste your time. If you don't know, if you want to learn, then only you can join. Okay? Any other doubt, bete? Just 3 more minutes. I will be here. If you want to ask any question, please ask. Yes, any question? Okay then. Yes, Dr. Hina, 48 hours. ना community नहीं, nosocomial hospital. Community नहीं, community तो कभी भी हो सकता है ना. Community is community. Hospital acquired nosocomial. ये क्वेश्चन है, रिपीट PYQ. डॉक्टर मुस्कान. अच्छा, okay. Yes. So Dr. Muskan, let us just take it out. Give me 1 second. I'll just take out where it is. Okay. Okay, बताओ बच्चा क्या डाउट है. ओके बेटा बताओ क्या बात है. अच्छा, ये वाला डाउट है. ओके, यस. सी बेटे. ओके, रिस्ट्रिक्टिव डिजीज में आरवी क्या हो रहा है, डिक्रीज हो रहा है, एंड टीएलसी क्या हो रहा है, डिक्रीज हो रहा है. इन इंट्रिंसिक आई टोल्ड यू वन थिंग. डॉक्टर मुस्कान, हिंदी इज फाइन विद यू और इंग्लिश, वट एवर यू से. यस बेटा. सी, आई टोल्ड यू, जब भी आप रिस्ट्रिक्टिव को पकड़ोगे, इट विल बी इंट्रिंसिक, मतलब फाइब्रोसिस. ठीक है. Somebody asked with fibrosis is what kind of respiratory failure? Mostly type 1, है ना. ये भी एक डाउट था किसी का. So mostly it is type 1. But बेटा please remember residual volume is decreasing. And see here, है ना, मैंने आपको बोला आप इंट्रिंसिक ही देखो. Until and unless they give you कि भाई in GBS what is happening, in polio, in paralysis what is happening, नहीं दिया है क्वेश्चन में. सिंपल दिया है रिस्ट्रिक्टिव मतलब फाइब्रोसिस मतलब इंट्रिंसिक. फाइन. सो इट इज लेस बाय लेस which is normal. Both are decreasing ना. Suppose let us say this was 10 and this was 11 suppose, है ना. दोनों घट गए. This was earlier 10 by 11. Fine. Now it becomes 8 by, let us say 8 by 9. So almost same, normal. Fine. In the extrinsic, which is due to the मतलब bony structure, scoliosis हो रहा है, kyphoscoliosis हो रहा है, right? Polio हो रहा है, then और GBS, Guillain-Barré syndrome हो रहा है, then then it is a different thing. In that case, residual volume remains same because lung is happy. Outside there are people are troubling, but TLC is low. So when the denominator is low, what is going to happen? RV by TLC will increase. Acha, okay, I have written decrease here, sorry. Okay, this is what you meant. Okay, yes, increase. Okay, yes, correct Dr. Muskan, correct. You're right. ठीक है. But बेटा extrinsic में हमेशा आपने ये बात याद रखना है कि जब भी restrictive पूछे, they are talking about fibrosis. Fine? Yes, Dr. Muskan. Okay, Dr. Harsh, I will try. Fine. I have kept it for the last few days where I will be dealing with the various, drugs which are acting together, right? Which are having some effect on each other. So that lecture I have kept. Yes, Dr. Muskan. Very good. Thank you for the correction. Very good. Thank you. This is like when we write, we make a mistake. Okay. Any other? चलो जाएं. चलो. Good night everyone. Please leave. Good night.